Thank you, Bob. Coming from a big BlackBerry user, the iPad has made a big difference in my life over the last 3 weeks. That's not an advertisement, or I don't, but it's transforming the world, I think. Now we're going to open this up to a Q&A, and Christy's going to have a microphone here in the center of the room. And as you're thinking about some questions, I see a hand up. I have two I'd like to lead off with. And the first one is, were the comparative effectiveness concerns accelerated by the passage of Obamacare and by the $1.1 billion or so stimulus funding? And what impact would Obamacare repeal make on comparative effectiveness? And the second question is, what are some practical steps that state legislators can do to address this issue? Twyla mentioned several issues. So number one is, what would be the impact of repeal of Obamacare on comparative effectiveness? And number two is, what are some practical steps as we as policymakers at the state level can and should do to make a difference here? And then we'll open it up for the next question I see. So anybody on the panel?
Let me suggest that repeal of Obamacare probably wouldn't have a significant impact on comparative effectiveness research, which is not to say there's not a huge number of reasons to repeal Obamacare. But most of the dealing with comparative effectiveness research is set up in the stimulus bill. The Center for it was set up there. The funding for it's there. There's some applications of it, particularly regarding Medicare, that are in Obamacare, and we'd be better off without. But the real issue is it was set up through the stimulus, and it's going to have to be attacked through a different mechanism than dealing with the just simple.
The only thing that I'll add is that, and I believe it is 20% of ARC's $1.5 billion that is going to comparative effectiveness research. I could be wrong on that. I'm trying to pull it up out of my memory. I know the 20% is accurate. And ARC is still around, and ARC, the Agency for Health Care Research and Quality, almost died in 1996. When the Republicans did not like the idea that they were going to try and control the practice of medicine, and then they managed to stay alive, and they continued to move in that direction.
Any practical steps for legislators before we go to the next question?
No, you can hear me, right?
Push the center button.
I really believe that there's a due process issue here. Oh, there you go. Hey. Hello, everybody. As Twyla indicated, all this CER stuff, which is pork, it is an incestuous swill of people deciding to give money to each other, and which is a subject which will be a focus of oversight hearings in the next Congress. How this money is doled out, and the fact that the money is given out to friends of people on the same committees that are overseeing the projects themselves. They're looking at average populations, and these average population will go into recommendations of what quality will be, and therefore, to the extent that reimbursement or quality decisions are made, and will go into how money is allocated to Medicaid, I think the states have an opportunity to say, you know what, it doesn't apply to our populations, doesn't apply to our special needs, it doesn't apply, and I think there's opportunities to challenge it there.
I'm going to suggest a slightly different direction, because I think the key is to move to a different type of reimbursement policy for your public programs, in which you're going to have to give people a more defined contribution type of approach, where they have a finite amount of money and then they decide how to allocate it. Because if you're going to have an open-ended funding scheme, then I'm sorry, you're going to have to use some sort of decision-making on how to allocate those resources. And I appreciate the story of Bob's daughter, but a doctor will always say, 10 more days and I can make a difference, especially if you're paying for it. And then after that, well, okay, we're almost there. Another 10 days would be great. And you could go on forever. And, at some point you have to say no.
I disagree with that. I fundamentally disagree with that. That's a myth. And especially, well, setting aside my daughter, I don't think, there are some physicians that will do that, but in point of fact, most doctors will try to deliver the best care to their. We're recording. Oh, I'm sorry. I think most doctors will try to deliver the best care for their patient based upon what they think is best. And no one wants to stay in the hospital for as long as possible. And I had
No, but we're not talking about venality here. But
Yeah.
doctors always think they can do, if they're given the chance, they can nobody wants to let their patient go. So doctors are always want to do a little bit more. Look, my favorite TV show for years was House. I love Dr. House. He'll come in, he'll try this, he'll try that. Well, okay, the patient's still dying, I'm going to try another thing. And he'll go on and on and on. We're not going to be able to pay for that for every patient forever. And ultimately, we're going to have to say, you want to do one more test? You're on, we're not going to pay for it. And then, not that the doctor's venal, but they want to save that patient.
But, the fact of the matter is, NPR, Minnesota Public Radio, went into Mayo Clinic, and they went into rounds, or a time where about there are 8 or 10 doctors sitting around together, talking about what to do with the patient. And they did not agree. They did not agree. They argued back and forth and left and right about what to do. The fact of the matter is there is no one right way for everyone. Another instance is 2 doctors that came up at a conference of, I don't know if it was internist or I'm not sure what it was. No, it was an ENT conference. And one of them argued for ear tubes for children and one of them didn't. Huge, passionate arguments, right? Peer-reviewed papers. And at the end of the day, what has to happen is that people have their own money to make their own decisions with their own doctors, and they go look online and they ask about those questions, and they go see a second doctor if they disagree. And the prices of today come down to where they are going to be lower as soon as we get all the bureaucratic administrative money out. And so there is no one way to treat everybody. Michael is right that as soon as the government is in, you have to have people saying, how are we going to stop this assault on the U.S. Treasury? Clearly, that's true, but it has to do with giving people money and telling them that they get to say no to themselves. And that also means that there shouldn't be 100% coverage at any time insurance.
well, yeah, here's an example.
10%. The patient should always pay 10% or something like that, so that they always have skin in the game.
Well,
And right now, we do not have a health insurance system. We have a prepaid coverage system, and even the argument for pre-existing conditions is what Van Jones called a radical kernel. Now, he didn't call it that, but I looked at it and I said, that's what that is. That when you have a radical, when you want to cover absolutely everything, and you don't want insurance to be insurance, you will get into the system where somebody else has to
Yeah.
say no.
Let's turn to a question in the back room. You all touched on a very important concept. That's personal responsibility, and the system is broken because it doesn't incentivize personal responsibility in the system and really seeking out the true cost. Ma'am, in the back of the room, you've had your hand up from the very beginning, and thank you for your patience.
Jane Orient from the Association of American Physicians and Surgeons. I think you came up with the answer just now, that the problem is third-party payment, and we'll never find out the answer until we send patients a bill. But I would like to take exception to a couple things that Michael Tanner said. First, let me say I think his article on Obamacare is wonderful, and I've quoted it extensively. But on this comparative effectiveness research, I mean, what questions are you trying to answer, and by what method are you answering them? I did look at this Oregon system, and I noticed that at the very top of the list there was thumb sucking. And when I pointed this out, I was accused of taking a cheap shot at this very scientific study and that they just needed to clean the data a little bit. But I'll still point out that quite far down on the list are things like corneal abrasions and kidney stones, which I guarantee would be your #1 priority if you happen to have them. So, I mean, how do you set up a study to, what question are you trying to answer, and how does your study get at answering it? I mean, like with prostate surgery, in first place, no surgeon is going to guarantee you 100% cure. But there's nerve-sparing surgery now, there's the Da Vinci robot, and there's all kinds of different types of radiation therapy. How do you design a study to compare them with any degree of meaningfulness?
The other alternative is simply, are you going to pay for everything? I walk into your Medicaid program.